Hi guys, so today we are going to talk about chapter 8, which is the joints of the skeletal system. So I'm focusing more on what you need to know for the final exam as far as the things go in red as opposed to exam 3 since it is so close anyway. So first off and most importantly, joints are also known as articulations, because they are basically the functional junctions between bones. So they articulate the bones together. They bind the parts of the skeletal system together so that the bones can actually work together in a more functional manner. They also make bone growth possible and permit parts of the skeleton to change shape during childbirth. Because remember, this baby has to come through a small birth canal to get out. So the joints make it possible for that to happen because the parts can move. And they also enable our body to move in response to our skeletal muscle contractions. So first off, joints can be classified in two ways, structurally or functionally. Structurally, they're classified as fibrous, cartilaginous, or synovial based on what they are made of. And functionally, they are classified based on how much they can move. So synarthrotic joints are immovable, amphiarthrotic joints are slightly movable, and diarthrotic joints are freely movable. So talking about structural classifications, so the fibrous joints are held together with dense connective tissue. They contain a lot of collagen fibers, and these are found in bones that are in close contact. So remember, collagen means strength. So fibrous joints are going to provide strength between those bones that are really close together. There are three types: syndesmoses, sutures, and gomphoses. A syndesmosis is a bone bound by a sheet of dense connective tissue. So that interosseous membrane between the fibula and tibia and also the radius and ulna, or a bundle of dense connective tissue like an interosseous ligament. Amphiarthrotic means that they are flexible to an extent, so they may twist. And that's the important part about the interosseous membranes between the radius and ulna and tibia and fibula, because these bones are really close together, but they have to be able to move a little bit. So that interosseous membrane helps them move while also keeping them stable. And again, lies between the tibia and fibula and the radius and ulna. Sutures are found between the fat bones and the skull. They are thin layers of connective tissue like a sutural ligament that connect the bones together. They are immovable, so they're synarthrotic. And finally, gomphoses are cone-shaped bony processes in a socket like in the jawbone. So the tooth and the jawbones are actually held in place by the periodontal ligaments, and they sit inside of the gomphoses. They are also immovable, so they're synarthrotic. The second type are cartilaginous joints. These are connected by hyaline cartilage or fibrocartilage, as the name implies. There are two types of cartilaginous joints, synchondroses and symphyses. Synchondroses are bands of hyaline cartilage that unite the bones together. Some of these are temporary, such as the epiphyseal plate. So remember, the epiphyseal plate is the growth plate. But as soon as we stop growing, ossification happens and changes that epiphyseal plate to a synostosis. Also between the manubrium and the first rib, so those costal cartilages that help connect the ribs to the sternum, these are permanent and they're synarthrotic, so they don't move. Symphyses are pads of fibrocartilage between bones. The articular surfaces are covered by hyaline cartilage, and they provide limited movement, so they're amphiarthrotic. The pubic symphysis is an example, and also the intervertebral discs, which are the joints between the bodies of adjacent vertebrae. Now remember, the pubic symphysis is between our pelvic girdle. So again, limited movement. The pubic symphysis will actually relax a little bit while we are giving birth so that the pelvic girdle can open up a little bit. But remember, it is cartilage, so it's attached. It's not going to detach or anything. It's just going to relax a little bit to provide a little give, so to speak. Synovial joints are most of the joints in the body. All of these are diarthrotic joints, so they provide mobility. The structure of a synovial joint is very important. The articular cartilage is going to cover the ends of the articular bones. And the joint capsule is what actually holds these bones together. Now, the joint capsule consists of two layers. The outer fibrous layer, which is composed of ligaments, and the inner layer, which is the actual synovial membrane. That secretes synovial fluid, which is going to provide lubrication to make it easier for these joints to move. So generally speaking, synovial joints are more complex than the other types, and they contain the articular cartilage, which again is on the end of the long bones, the joint capsule, which surrounds it and holds those bones together, ligaments, which of course are going to stabilize it, the synovial membrane, synovial cavity, and synovial fluid, which is the area that makes it a synovial joint, and that fluid is going to reduce friction between bones. And then the meniscus is in some joints. Menisci is the plural form. Bursae are in some joints. Bursa would be the singular form. So here's the knee joint showing you a typical synovial joint, as well as some less common structures like the menisci and the bursa. So look at the menisci in this particular knee joint. You can see it down there. If you look at that subpatellar fat, the yellow kind of draws your attention to it. There's the menisci. There are 6 types of synovial joints. They're classified by shape and the type of movements they allow. The ball and socket joint is also called the spheroidal joint. It has a round head inside of a cup-shaped cavity. So it kind of sits like this. This provides the widest range of motion. It is multi-axial, plus provides rotation. The hip and shoulder joints are the best examples of these. And as we know, we can move our shoulders a lot, we can move our hips a lot, our legs around. It's also important to note that the acetabulum of the pelvic girdle, where the head of the femur sits, is deeper than the glenoid cavity, where the head of the humerus sits. So that's why our shoulders get dislocated a lot easier than our hips get dislocated. Second type is a condylar joint. It's oval, condyle, fits into the elliptical cavity. So it provides back and forth and side-to-side movement. There isn't any rotation, so it's not as functional as the ball and socket joint, but it does provide biaxial movement. So these are the joints between the metacarpals and the phalanges. A plane joint is also called a gliding joint. It's almost flat, but may have a slight curve to it. It provides back and forth and twisting movements. So these are going to be our wrist and ankle joints. Now, if you think about it, our wrist, those bones have to move a little bit, but they're really close together and they don't really move a lot. They have to provide some give, so to speak, so that they're not breaking all the time. But they don't move a ton. So that's why they are plane joints or gliding joints. Just think about it as they just glide along each other a little bit. The hinge joint is a convex surface that fits into a concave surface. It provides movement in one plane, so uniaxial movement. And the joints between the phalanges and our elbow is a hinge joint. The pivot joint is also called the trochoid joint. Cylindrical surfaces rotate within the ring of another bone. This only provides rotation, uniaxial movement. So the example is the atlas C1 and the dens of the axis C2. So that's what provides our head to be able to move from side to side. Saddle joints are also called sellar joints. They have both concave and convex surfaces, biaxial movement in two planes. So the carpal and metacarpal of the thumb are examples of a saddle joint. So if you learn these joints on your body, think about it, you're always going to have your body with you when you're taking a test. So you can actually do these movements, you can look at the joints, you can see how they move, you can see what they can do. So try to practice them and learn them on yourself, and it's going to be a lot easier when you're taking a test. So actions of skeletal muscles produce movements at synovial joints. The relatively fixed end of a skeletal muscle is called the origin. The more movable end is called the insertion. So movement at a joint occurs when a muscle contracts, and the fibers are going to pull the insertion towards the origin. There are different types of special movements, and again, learn these on your body, because when you're taking a test, you can actually do the movement and see what's happening. So you've got abduction and adduction. Abduction is moving away from the body. Adduction is moving towards the body. So think about it as when you're adding something, you're adding to it, so you're going towards your body. Maybe that will help. Then you've got flexion and extension. So flexion is going to decrease the angle between joints. Extension is going to increase the angle between two joints. So think about it as when you're extending your leg, you're extending the angle between the joints. Hyperextension, of course, is when you go a little too far and you overextend it. Lateral flexion is just going to the side. Dorsiflexion and plantar flexion are special movements of the foot. Dorsiflexion is when you move your foot up. Plantar flexion is when you move your foot down. So maybe if you remember your plantar flexion, you're planting your foot into the ground, so you're moving it down. Circumduction and rotation, you're moving your arms in circles, so circumduction. And then rotation, you have medial rotation and lateral rotation. So medial is going towards the medial, lateral is going towards the lateral, basically. Supination and pronation are special movements with the hands and forearms. So if you have your forearms up, sorry, it's probably a bad picture, but you move them up, and that's supination, down is pronation. So how I remember it is kind of silly, but supination, if you're asking for soup, your hands are in the upright position. So you move your forearms to where your hands are up. You want some soup, that's supination. Inversion and eversion, again, special movements of the foot. So inversion, the inside of your foot is up. Eversion, the outside of your foot is up. So remember, inversion, inside of foot up. Protraction and retraction are special movements of the mandible. Protraction is when you move your mandible out. Retraction is when you move it back. Elevation and depression, you've got elevation, depression. We're going to go through some more complex synovial joints, the shoulder, the elbow, the hip, and the knee. So the shoulder, again, is a ball and socket. The head of the humerus and the glenoid cavity of the scapula meet and form the ball and socket joint. It's a loose joint capsule. So remember I said the glenoid cavity is a pretty shallow depression. So the head of the humerus doesn't fit too snugly in there, which is why our shoulders can dislocate so easily. Ligaments are in place to prevent displacement, but it does happen. There are several bursae that are going to help cushion and reduce friction, and there's a very wide range of movement, including rotation and circumduction, that we can do with our shoulders. The major ligaments, you have the coracohumeral ligament, the glenohumeral ligaments, and the transverse humeral ligaments. The elbow joint contains two articulations. The hinge joint between the trochlea of the humerus and the trochlear notch of the ulna, and this provides flexion and extension only. And then the plane joint between the capitulum of the humerus and the fovea on the head of the radius. This is what provides that pronation, supination we were just talking about. And there's several reinforcing ligaments here as well. The major ligaments of the elbow joint that we care about are the radial and ulnar collateral ligaments and the annular ligament. The hip joint, again, a ball and socket joint, but the head of the femur and the acetabulum of the hip bone fit much more deep and cushier, so it's a lot more stable. The acetabular labrum kind of helps stabilize it as well. There's a very heavy joint capsule and a lot of reinforcing ligaments, so that we have a variety of movement, but not as much as the shoulder joint because it's so much more stable. The major ligaments are the iliofemoral ligament, which is the strongest ligament we have in our body, the pubofemoral ligament, and the ischiofemoral ligament. Our joints tend to wear out as we get older, and they can be damaged by either injury or arthritis. We can replace some of the joints, like use steel and titanium to replace the larger joints, silicone for the smaller joints, and some even are ceramic. Hip replacements are the most common, and as I said, as we get older, our joints just tend to wear out from use. the articular cartilage starts to wear against each other. You're going to lose some of the synovial fluid. And once the cartilage and even the menisci start to deteriorate, you can go in and shave it off. And that's like a temporary fix. Or again, if it gets bad enough to the point that you might need a replacement. We do have new technology, so we use materials that resemble the natural body chemicals. We can coat the implant with hydroxyapatite, for example. 3D printing technology is also used to create custom replacement joints. The knee joint is the largest and most complex joint that we have. The 3 bones, you have the femur, the tibia, and the patella. The femur is at the medial and lateral condyles of the distal end. The tibia, the medial and lateral condyles of the proximal end. And the patella articulates with the anterior surface of the femur. It is strengthened by a lot of ligaments and tendons. There are bursae that help cushion it, pads of fat, and even menisci that separate the femur and the tibia to, again, help prevent the bones from making that bone-on-bone connection. There's a lot of major ligaments, the patellar ligament, the oblique and arcuate popliteal ligaments, the tibial and fibular collateral ligaments, and the anterior and posterior cruciate ligaments. The last 4 are probably the most common that we talk about, the tibial and fibular collateral ligaments and the anterior and posterior cruciate ligaments. We call them the 4 C's. So those are the ones that you probably want to familiarize yourself with. If you've ever heard of a torn ACL, that's the anterior cruciate ligament. Characteristics, it's a modified hinge joint between condyles and provides flexion and extension. Some rotation a little bit when the knee is flexed, but obviously you don't want too much or you're going to tear something. The plane joint is between the femur and the patella, so it kind of just glides along it. Disorders, we have sprains, which is when you tear the connective tissue in the joint without doing anything to the bones. Bursitis, those bursa that help cushion and prevent injury can actually become inflamed from overuse or stress. And of course, arthritis, if you have inflammation, swelling, and pain in the joint. Could be caused by rheumatoid arthritis, which is an autoimmune disorder. Could be caused by osteoarthritis, which is degenerative, and this is the most common type. As we age, our bones start to deteriorate, our joints start to deteriorate, and osteoarthritis is a result. Or it could be caused by Lyme disease through a tick bite, and when that happens, it's called Lyme arthritis. As we get older, our joints get a lot stiffer. That's a sign of aging. Many people develop arthritis as they age. As I said, we start to lose that elasticity. We start to lose our bounce, so to speak. We start to lose the synovial fluid, so our bones might start to actually rub against each other. The fibrous joints are the first to change. They can strengthen over a lifetime, though, if you work at it. Cartilage and synchondroses tends to stiffen up, and as I said, those ligaments lose their elasticity. The changes in the symphysis joints of the vertebral column, the fibrocartilage starts to lose water, and they're not as flexible anymore. So normally when you are walking or doing whatever you're doing during the day, those fibrocartilage discs kind of cushion it. And then when you sleep at night, they have a chance to rebound, and they gain their water back and go back to their original thickness. But as we age, we lose that water, and those cartilage discs tend to lose their flexibility. And you are actually a few centimeters shorter when you are older than when you were younger, because now when you go to sleep, your discs do not regain their water and regain their flexibility. Synovial joints lose function, capillary supply starts to diminish, nutrient supply starts to get hampered, and you can't do as much as you used to be able to do because you start to get stiffer a lot faster. Activity and exercise can keep joints functional longer, but keep in mind it's kind of like a double-edged sword, because activity and exercise is good for you and it can help your joints, but you're also going to be using them more. So these changes can happen as well. So the joint movements, again, when you're moving a part away from the midline of the body, it's abduction. but towards the midline is adduction. So like I said, think about it as you're going towards the midline, so you're adding to it. Decreasing the angle between two joints is a flexion. Increasing it is an extension. So as I said, think about you're extending the angle, you're increasing the angle, your extension. At the ankle, movement that decreases the angle between the foot and the shin is dorsiflexion. Movement at the ankle that increases it is plantar flexion. So remember I said think about planting your foot, plantar flexion, moving down. When a part moves on its axis, it's rotation. Circumduction is moving in a circular motion. Turning the palm upward is supination, downward is pronation, so ask for that sup. Moving the sole of the foot to a lateral facing is eversion. Moving it to a medial facing is inversion. Forward movement is protraction. Backward movement is, that says protraction, I should say retraction, I'm sorry. Forward movement is protraction. Backward movement is retraction. Lifting a part up is elevation. Moving it down is depression. So that is all I have for now. As always, if you have any questions, just send me a message. Otherwise, I will see you for the next chapter. And remember, learn these on your body. And that should say backward movement is retraction, not protraction. So I will talk to you later. Bye.